this very short voiceover is going to be on parathyroid function, or a matter of calcium levels. Now, the parathyroid gland actually consists of 4 small glands in the back of the thyroid itself, and they secrete parathyroid hormone, or PTH. PTH regulates both calcium and phosphorus. Now, the parathyroid gland helps regulate calcium by doing several things. Number 1, if there is a decrease in calcium, parathyroid hormone is stimulated to be secreted. If the calcium is high, the parathyroid hormone is shut down. This calcium concentration works directly on the parathyroid gland without any influence of other hormones or nerves. Now, parathyroid hormone does 4 things. Number 1, it increases the movement of calcium from bone into blood. It stimulates the activation of vitamin D, which increases absorption of calcium from the intestine. The third thing it does is to stimulate renal reabsorption of calcium. And the fourth thing is it decreases the reabsorption of phosphate, so it is eliminated by the kidney. Now, it's important that phosphate be eliminated by the kidneys, because when the parathyroid hormone works, it causes both calcium and phosphorus to be released. And if both remain high, then crystals can be deposited back into the bone and other tissues. Now, calcium is actually regulated by both parathyroid hormone and calcitonin. So if you follow along on this schematic here, so if we start at 1, if calcium levels rise above a set point, the thyroid gland releases calcitonin, which actually inhibits osteoclasts. And if you remember, they break down bone. So if you inhibit them, you're going to cause the blood calcium levels to fall. If the calcium levels fall below a set point, then the parathyroid gland kicks in, releases the parathyroid hormone, and it does all of its things, and then the blood calcium level rises. So this is the negative feedback system that works, but it works in conjunction with both parathyroid hormone and calcitonin. Now we're going to look at both hyperparathyroidism and hypoparathyroidism. So for hyperparathyroidism, there's an increase in PTH, which increases the bone loss of calcium. Chronically, high calcium creates deposits in soft tissue. Now, there are several causes of hyperparathyroidism. The primary cause includes benign adenomas, and patients who have had radiation to the neck are at increased risk of developing these adenomas. Secondary causes are related to conditions that cause hypocalcemia, and that is vitamin D deficiency, malabsorption, chronic kidney disease, and hyperphosphatemia. Tertiary problems include hyperplasia of the parathyroid gland with a loss of negative feedback. This seems to occur with kidney transplants in patients who have been a very long time on dialysis. Now, you diagnose this with serum calcium levels, which usually exceed 10 milligrams per deciliter. The normal values are 8.4 to 10.2, and phosphorus levels that are low, less than 3 milligrams per deciliter, and the normal values are 3 to 4.5. Now, they also may check alkaline phosphatase levels and do DEXA scans, as we learned in our orthopedic lecture, to check bone densities. They also may do a CT scan or an ultrasound of the thyroid gland to look at the parathyroid glands themselves. Now, these patients also suffer from chronic renal failure and fragile bones, and we're going to look in a minute to see why that is. As far as assessment goes, you're going to see, as we stated before, an elevated calcium and a decreased phosphorus, and that's because of the function of the parathyroid hormone. There's also decreased bone density because of the breakdown of bone, which leads them to have pain and be at risk for fractures. They also suffer from fatigue and muscle weakness related to the function of calcium in the central nervous system. They suffer from nausea, vomiting, anorexia, and weight loss. And a big problem is renal stones, because an increase in urinary calcium and an increase in phosphate leads to calculi formation. And another biggie are cardiac dysrhythmias, because calcium is intimately involved with cardiac function, and having hyperphosphatemia can actually mimic having an MI. So what do we do for these people? Well, the first thing we do is we provide them with IVs for hydration, and then we give diuretics to increase the urinary excretion of calcium. We also can give them oral phosphates to inhibit calcium absorption effects of vitamin D, but this can put them at risk for renal calculi, so it's only used if the patient has normal renal function and low phosphorus levels. They can also give them calcitonin to decrease the release of calcium from bones, but surgery is the most effective treatment, and it's usually done on an outpatient basis with an endoscope. Then the normal parathyroid tissue is actually transplanted into the sternocleidomastoid muscle, or thereby, or in the forearm, so that you can maintain a normal feedback system of calcium. Now, post-op parathyroidectomy is about the same care as your thyroidectomy patients. Big problems are airway because of edema and hemorrhage, and they're both similar to what happens with a patient who had a thyroidectomy. It's important to monitor their calcium levels because they may have mild tetany, which is an unpleasant tingling of the hands and around the mouth. Or they can have severe tetany, which leads to muscle spasms and laryngeal spasms. You treat this with IV calcium gluconate. Now, hypoparathyroidism is very rare. The most common cause is iatrogenic, which includes removal of the parathyroid glands or damage to the vascular supply of the glands during thyroid surgery or radical neck resections. Signs and symptoms are related to decreased calcium. So you're going to have numbness and tingling, muscle cramps, and positive Trousseau's sign, which, if you remember, is if you inflate a blood pressure cuff, it leads to spasm of the muscles in the forearm. So if the hand is supinated, it becomes pulled towards the blood pressure cuff. Or Chopstick sign, which is the tapping over the facial nerve, leads to twitching of the facial muscles. And they can also suffer from seizures. So how do we treat this? Number one, we give IV calcium chloride or calcium gluconate, and this is if it's severe. You have to do this slowly with EKG monitoring because they're at risk for cardiac arrest. And this is particularly important for patients who take digoxin because they are very vulnerable to cardiac dysrhythmias with these calcium injections. These medications are also very irritating to veins, so you have to ensure that there's a patent IV so you don't get extravasation of it out into the tissues. Interestingly, just for kind of some immediate relief, you can have the patient do some rebreathing into a paper bag. And how this works is there's a decrease in CO2 excretion from the lungs. That increases the H2CO3, or carbonic acid, which lowers the pH of the blood. With a lowered pH, you have calcium that ionizes and makes more of the total calcium available to the body in an active form. Now, these patients may also need magnesium replacement, and they also have to avoid high phosphorus foods. And these include sardines, salmon, tuna, whole milk, cheese, yogurt, cereals, nuts, lentils, and the poor old sunflower seeds. They also may need long-term calcium and vitamin D replacement. And that is my very short lecture on the parathyroid gland.